Welcome back. And today we'll be discussing the interpretation of parenchymal abnormalities on an HRCT or high resolution CT scan of the lung. So this will be part 12 in our approach to chronic dyspnea, and this will be the prelude to our discussion of individual topics. That is namely the topics that I had discussed as the 5 initial differential diagnoses in our first video in the series. So let's start with this. The basic setup is that a patient has been placed inside a CT scan machine. A CT scan machine is basically contains an X-ray source. So this is your X-ray source, passes X-ray beams through the patient, in this particular case in a fan beam geometry, and it is detected by some detectors that are located behind the patient, and then the entire setup actually rotates around the patient 360 degrees, and in this process you're able to create shadows of the opacities within the patient or the patient's body, and those are then essentially mathematically superimposed upon each other to produce a image. The details of this are presently beyond the scope of this discussion. However, we'll be getting into it later in a detailed discussion. This is your lung, the schematic of the lung that we've been using to understand our symptom analysis and the examination of the pulmonary system. Now, what I've done is I've also added an anatomically accurate pulmonary lobule. So this is the basic subunit of the lung parenchyma. So this is the bronchopulmonary lobule. Okay. Now in this lobule, I'll show you a larger image of the same in the next slide. So now what we've done is I've enlarged it, and once I enlarge it, what you'll see is that it's actually quite intricate. Anatomy of the bronchopulmonary lobule is quite intricate and contains a lot of small structures which in some clinical radiological context become relevant. So let's just review the anatomy here. So what happens is that as the pulmonary artery branches through various orders of branching into the pulmonary parenchyma, eventually it enters the pulmonary lobule. So this red structure here, that is your pulmonary artery branch. Okay, now this is right next to this pink structure here. So the pink structure which is behind the pulmonary artery, I'll just highlight it here. These are actually the branches of the respiratory tree. Okay, so this represents your terminal bronchiole. Okay, and that terminal bronchiole is then dividing further and further. So if you recall, there are 23 generations of branching in the respiratory tree, and the terminal bronchiole then divides multiple times to produce the respiratory bronchiole, the alveolar ducts, and then the alveoli. So those are the last 3 orders of branching. Fine. So that's your terminal bronchiole. Now along with that, you can see there are green structures. So there are green lines here. These represent the lymphatics. Now importantly, the lymphatics drain both via the base of the bronchopulmonary lobule. These are the lymphatics. They drain from here, so they go like this. Additionally, they also go along the septae. So lymphatics drain along the septae as well. So lymphatics are present in both locations. Now the venous supply or the veins that form after the blood has passed through the alveolar walls or the capillaries around the alveolar walls, that passes through the septum. Okay, so this is how it passes. So this is the detailed understanding of the anatomy of the bronchopulmonary lobule. Now once you've understood this, we'll see how it looks on a cross-sectional image, because that is what you see when you do a CT scan. So essentially what we do is we pass a X-ray beam like this across the patient's chest, or if I take a magnified view, I'm basically passing a X-ray beam or a large number of X-ray beams through the patient's chest like this. Okay, now what do? I essentially look at the cross section. So what would the cross section look like? So this is your normal bronchopulmonary lobule. I passed an X-ray beam through it. Now we'll see what the cross section looks like. So the cross section would look like this, and you can see this is the pleural membrane or the interlobar septum rather, and we see that the septae are now forming these polygons. I made them pentagons, but they can be polygons. They could have any number of sides, usually 4 to 6. Now you can see in the center of the polygon you've got three structures. You've got your pulmonary artery branch, that will be the red structure. We've got a lymphatic branch, that will be a green structure, and we've got your branches of the respiratory tree. Okay, that would be your pink structure. Okay, now in the walls of the septa we have two structures. So if I take the cross section here, that is, you have your lymphatics, so the green structure, okay, and you have your vein. So this is what you would expect to see, but the thing is that there are limits to the image resolution of a CT scan. Okay, so usually structures that are so small, so you can see that from the center of the of the polygon to the end of the polygon, it's around 5 millimeters or half a centimeter. However, the limits of resolution are around 1 millimeter, and you can see that compared to the size of the polygon, the septa, the small dots, our CT scan image is not able to, in a physiologically normal lung, delineate this much fine detail. So what we end up with is not this image, rather we end up with this image. The visceral pleura, that is thicker than 1 millimeter, so that is visible. Okay, and usually one of the branches, that is the terminal branches of the pulmonary artery, is visible. Okay, so that is what we're getting here. But other than that, and this is barely visible. Okay, this is barely. Sometimes, especially if you're a novice reader, you're unlikely to see it. So it essentially looks like a completely black structure, okay, with some dots in between. This is the normal appearance, but in pathology it changes. So how does it change in pathology? So this discussion will focus on lung attenuation being increased. That means there is some extra tissue there that is, attenuating your X-ray beams more than would have been expected. Okay, so what would that look like? So again, starting with the bronchopulmonary lobule. This is a bronchopulmonary lobule. Now I'm going to pass an X-ray beam through it, get a cross-sectional image of that of the bronchopulmonary lobule, and essentially this is what it looks like. Okay, but like we've just discussed, this is not actually what it looks like. This is what it looks like. Say there is something occupying the alveolus completely. So some material has occupied the alveolus completely. It has completely replaced the air within the lobule, within the alveoli or even around the alveoli. Okay, so what do we see? We will see a diffuse, almost confluent, relatively homogeneous opacity like this. Okay, this opacity is then called a consolidation. So this is called a consolidation. Okay, now what else could happen here? What else is possible? So once I remove the consolidation, what else is possible? So the next thing that could happen is you could have some thickening of the septa. Okay, so in this particular situation I've shown, you got thickened septa. So now what happens is that in the image you'll actually end up being able to see the polygon. You'll be able to see the sides of the polygon. Okay, so this becomes how the polygon is visible to you. So this is not normal. So this is called septal thickening. Okay, this is a type of interstitial pattern. Okay, now what else could happen? The consolidation that we just discussed, that consolidation may be due to something that has got putting a positive pressure around it. Okay, so it could form a round mass like this. This mass is then called a nodule. So a nodule, so variants of a consolidation, technically one would be a nodule. If there is it appears to create a outward pressure on the surrounding lung parenchyma. On the other hand, we could also have consolidation because these alveoli have essentially collapsed in on themselves. So there is no extra tissue within the alveoli, but the air within the alveoli is no longer there. So because the alveoli have collapsed in on themselves, now the tissue density has increased, but obviously the total volume, the tissue is not, there is no extra tissue there, so the total volume has decreased. So there will be essentially a loss of volume, and that we call an atelectasis. or collapse. Okay, so consolidation, atelectasis, and nodules, all three of them actually look very similar to each other, as homogeneous, relatively homogeneous, white opacities on an HRCT and even on a chest X-ray. However, consolidation does not have concomitant loss or increase in volume. Okay, whereas a nodule may show features of increased volume and usually very sharply demarcated, whereas atelectasis has loss of lung volumes. Okay, and we'll see how this looks in detail. Now, in addition to that, you can see that even though we are taking a cross section of the lung, the actual physiological movement of things into and from the lobule are in different directions. So blood is coming in from the pulmonary artery branch and extending through these branches and going into through the capillaries. So anything that comes through blood, hematogenously spread infection or say metastasis, that would get stuck along these branches. Okay, so that would produce a certain pattern. Now similarly, if you have say lymphatically spread process, most immune processes, whether they are caused by an infection or not caused by an infection, they would be spreading along the lymphatic. So they would go like this and they would go like this. So they would get stuck along the lymphatics here. They would also get stuck in the center because the lymphatics also extend through the center. Okay, so that would be another pattern. On the other hand, if something was coming in through the respiratory tract, okay, it would get stuck within the respiratory tract. Now importantly, the respiratory tract is here, the branch is here, but we can't really see it. So we can't really tell whether it is from the respiratory tract or from the pulmonary artery. And you could, under some circumstances, have inflammation around the pulmonary artery. So either something coming in through the respiratory tract or something inflaming the pulmonary artery or branch would result in a nodule right in the center of the bronchopulmonary lobe. So these are what I call nodular interstitial opacities. So these are interstitial as in they're very small, okay, and they follow the interstitial patterns of the lung, and they are nodules, so they are not actually continuous with each other. They are nodular interstitial patterns. Okay, so this is the entire gamut of or the entire spectrum of increased opacities that you may get on a HRCT of the lung. There is one more called a ground glass opacity. A ground glass opacity essentially is any opacity of any of these opacities that is so small that it is not really cannot be resolved as multiple separate pixels or multiple separate imaging points in the image, and therefore is shown like a haze, and it appears like you're looking through a tinted glass window. Okay, and so that haze allows you to see the underlying bronchopulmonary architecture, but it is not as black as the rest of the lung. Okay, so that is what we call a ground glass opacity, and essentially it could be a prelude to consolidation. It could be a prelude to interstitial opacities. So it is a rather non-specific finding. It could go either way. Yeah, so we've just discussed interstitial patterns. Like I said, it could be septal thickening. So septal thickening would look like thickening here, and you would end up seeing the lobule as well. Okay, so this is how the septal thickening would be. And we could have multiple forms of nodular interstitial opacity. So you could have a nodule around the central artery like this. So they would form like this. And we'll be getting into the details of that. And there are 3 patterns of nodular interstitial opacity. Now, let's talk about these patterns a little bit more in detail. So the first pattern is consolidation. Now, consolidation, importantly, can be acute or chronic depending on the clinical presentation of the patient. That is why we'll be going first through the clinical and pathological diagnostic framework and then coming up with the imaging, not directly going into imaging. Okay. Now the thing is that, and chronic would mean more than 4 weeks. Okay, there are some imaging things also, imaging patterns or concomitant findings that would indicate acute versus chronic pathology. For example, fibrosis would indicate chronic pathology. However, we'll get into the weeds of it later. Depending on how diffusely it involves the lung. It may be a focal pathology, it may be a multifocal pathology, or it may be a diffuse pathology, and this is rather subjective. Now, acute processes can be any three of these processes. So that is something, either of these three things can be there. However, chronically, a diffuse process would affect too much of the lung, and the patient probably wouldn't be able to survive that. So chronic consolidations are either focal or multifocal, and this will be a process topic of discussion in one of the subsequent videos. So we call it a chronic focal or multifocal consolidation. And you can see here we've got consolidation. This area of consolidation is relatively homogeneous. This area is not as homogeneous, and there's a little bit of ground glassing here on the sides here as well, okay, and on the other side of the line. So this is what we call a multifocal consolidation. Okay. Now the next thing is atelectasis. So atelectasis, like I said, there would be loss of volume. Okay, so here I've taken the example of a right middle lobe collapse. So what you can see is that the right middle lobe, this is a lobar collapse, the entire lobe is collapsing. So the right middle lobe actually collapses medially and downwards. So what was here has now collapsed here, and this is this wedge-shaped opacity that you're seeing here, that is obscuring the right cardiac bottom. Now on a lateral x-ray, it forms this kind of wedge-shaped opacity, and you can see that wedge-shaped opacity here. Okay, so this is the right middle lobe collapse, and what I want you to take from this is that there is loss of volume. So atelectasis is a consolidation with concomitant lung volume loss. What about a nodule? So a nodule is a very well defined airway opacity, which is either has very sharply demarcated borders, or it produces a positive pressure, or pushes things away from each other. Okay, so it's slightly of sometimes when a nodule or a mass or a consolidation can be confused with each other, but usually the sharp demarcation is what delineates the two. Okay, now we come to ground glass opacity. Now, even though I said ground glass opacities are non-specific, if in isolation, if there is no other imaging finding other than for consolidation, then we have a very limited differential diagnosis. So here you can see there is some ground glass consolidation here, okay, and essentially nothing else is there, everything else is normal. Okay, so when you have isolated ground glass opacities, please remember it has to be truly isolated. There should be nothing else on the imaging except for ground glass opacities. There are only 5 differential diagnoses. Okay, and I use the mnemonic order because it brings order to your differential diagnosis. So order stands for O for opportunistic infection. Obviously this would be in the appropriate clinical context. Okay, so this would be in a patient who is either has an immunosuppressed status or has a hematological malignancy or some kind of bone marrow failure resulting in neutropenia, something like that. Okay, so we'll get into the clinical details later. Now the second is R. R stands for respiratory respiratory bronchiolitis related ILD. So this is RBILD, not RPILD. So respiratory bronchiolitis related ILD or desquamative interstitial pneumonia. These are both smoking related interstitial lung disease, and we'll be getting into them later. Then D stands for diffuse alveolar hemorrhage. Okay, so DAH when mild can look like this. Then we have excess, E standing for excess alveolar fluid or pulmonary edema or ARDS, and that could be either. And then we have R. R stands for reaction to drugs. Okay, it could be a reaction to other things also, but usually drugs or blood products. Okay, so there can be a reaction. So that's a capillary leak. Okay, so that is your differential diagnosis, isolated ground glass opacity. Now you would have noticed that I have not given you differentials for consolidation, atelectasis or nodules because these are considerations that warrant a lot of clinical consideration before you analyze the image, and the image usually under most circumstances will not give you anything other than what you have gleaned from your clinical status. So right now I want you to only understand that isolated ground glass opacities have a narrow differential. The others have a very wide differential. That is very important it is very important to analyze that in the right clinical context. Now coming to our interstitial opacities. Now interstitial opacities are, first of all, what are they? Okay, so they are opacities that highlight the pulmonary interstitium, which we've already seen is not normally visible on HRCT. So the first type is a reticular interstitial opacity. So a reticular interstitial opacity, what you see is you have these multiple lines that appear to overlap with another like this, and they produce a net-like pattern. So reticular essentially means net-like. Okay, so that is a reticular interstitial opacities. And again, the distribution of these pathologies in imaging gives you an idea regarding what might be the cause, and we'll be discussing that as a separate topic. Now, nodular interstitial opacities are those nodular opacities highlighting the interstitium that may or may not, fuse with each other to form continuous lines, but usually don't. Okay, so let's see what we have. So this is the normal bronchopulmonary architecture, lobular architecture in cross section, and this is the actual CT image. So we've already discussed this in detail. So this is our this is your bronchopulmonary lobule. Okay, now this bronchopulmonary lobule, interestingly, in this particular first example, what we have is we have an opacity that is developed in the airway. Okay, now similarly an opacity could develop along the main artery at the center of the lobule. Okay, now similarly, because the bronchopulmonary the conducting respiratory system is branching for distally, you could have opacities along that branching as well, and these opacities could start to fuse with each other, to become continuous with each other if it is a structure, or it is say an infection or some kind of neoplasm that is growing within the walls of the bronchioles. Okay, so they would tend to fuse with each other like this. So then we pass X-ray beam through this structure, okay, at 1 millimeter this thing. So it's a high resolution CT, so 1 millimeter cuts. Now we get images like this. Okay, and what would the images look like? So the images in this particular scenario, they look rather similar if you see this. Okay, so there would be a thickening here, or there may be a thickening here, and like I said, in a normal circumstance I'm not going to be able to differentiate it. Okay, so what I end up getting is I end up getting some, I can now visualize the bronchioles within the pulmonary parenchyma. Okay, so here, or I could even visualize the branch pulmonary artery demodistally. So those are symmetrically placed around this central structure, so they are actually branching like this, and it is distally also there is an opacity. So okay, this pattern is what we call a centrilobular pattern. Okay, so now a centrilobular pattern therefore can be due to essentially one of three things. There could be involvement of the terminal bronchiole, there could be involvement of the pulmonary artery, and there is a small possibility that there could be involvement of the bronchiolar the branches of the bronchiolar arteries. But that is because bronchiolar arteries are actually supplying the vessel wall of the pulmonary arteries, and therefore it would cause inflammation in the pulmonary arteries. Okay, so you would have we could have involvement of the terminal bronchioles, we could have involvement of a pulmonary artery branch either directly due to vasculitis or in inflammation within its wall, or secondary inflammation due to inflammation in the vessels that are supplying its wall. Okay, so this is the pattern that you get. Okay, as you can see, all of the dots are separated from each other quite nicely, and they seem to be almost repelled by the fissures and the the sides, the visceral pleura. So what could be causing this? So it could be something in the terminal bronchioles. So what would reach the terminal bronchioles? Whatever is being hit. So structures or particulate matter that is less than 20 micrometers in diameter often is inhaled deeper into the lungs. So for example, smoke or small organic particles like you find with hypersensitive pneumonitis, or any infective agent, because all of them are obviously microscopic, end up reaching this area. Okay, similarly, you could have a bronchial artery branch getting inflamed due to either vasculitis within the bronchiolar artery. Okay, sorry. You could have the pulmonary artery branch getting inflamed because of inflammation along the pulmonary artery wall, which can happen with any vasculitis. Similarly, you could also have a pulmonary branch directly getting involved in vasculitis, and we'll discuss later. Pulmonary vasculitis in isolation is a very rare thing. It happens only with two diseases, that is Takayasu osteoarthritis and Behçet's disease, and those are themselves quite rare. TAC is not that rare in India, but it's rare, outside of the subcontinent and outside of South Asia and Southeast Asia. So that is why vasculitis or a inhaled particulate matter less than 20 micrometers would result in this kind of pattern. Okay, and the thing is, if I really can't differentiate between the two, okay, unless what happens is that the pathology that is growing within the bronchioles starts to branch and fuse with each other. Okay, so when they start to fuse with each other, what I find is that they form this kind of pattern in which there is seed or a bud, from which there is branching outwards. So this is called a tree in bud pattern. So tree in bud pattern, what does it imply? It's a centrilobular pattern that has a nodular pattern which has become where the nodules have fused with each other. So obviously this would not happen if it is a pulmonary artery branch, because the inflammation will not spread along the wall of the pulmonary artery branch. However, so a tree in bud pattern almost exclusively implies that there is an infective pathology that is growing within the bronchiolar lumen. Okay, the other non-infective pathology like hypersensitivity pneumonitis would not grow because it's just inorganic particulate matter. It is not a pathogen. So it indicates an infection. It is specific for infection, not specific for any particular infection. That is what you need to glean from it. So this is what a tree in bud pattern looks like. Okay, so we've got actually centrilobular nodules here. You can see these are spaced out from each other, avoiding the fissures, avoiding the wall of the pleura. However, in some locations they are tending to fuse with each other. That is what we call a tree in bud pattern. What we can say definitively about this is that this is a infective pathology. That is what we can say. Okay. Now next is what we call perilymphatic. So as the name would imply, we are going along the lymphatics. Lymphatics are passing through the septa between the bronchopulmonary lobules. They are also passing through the center or the hilum of the bronchopulmonary lobule. So we'll get nodules that are there on both sides. And the other thing is that the lymphatics are essentially, it's a continuous flow. So the nodules appear to almost be springing out of each other or appear to be talking to each other. So they appear rather social. Okay, that is the term I use. Now, if I pass X-ray beams through this structure, what I end up with is this. Okay, I get nodules along the septa. I also get some nodules in the center. Okay, and these nodules, as you can see, they tend to be they're coming out of each other. Okay, so they are like essentially clustering together in groups. Okay, or they are socially clustering. Okay, so as you can see clusters in both in the center of the lobule and with each other. So obviously we can't really tell which is the center of the lobule, which is the septum. But what we can tell is that the nodules are not sparing the pleural membrane, okay, or any septal membranes. They are also not. They are also appearing to talk to each other. Or they are social with each other. Now the other thing is, because the interstitial lymphatic fluid obviously passes through the lymphatics. If there is an obstruction to the lymphatic, sometimes the septum can become edematous. You might be able to actually see the septal wall. So that is very telling. That means it's definitely perilymphatic. Okay, so what does a perilymphatic pattern indicate? It indicates that it is either something within the lymphatics. Okay, so it could be an immune process, it could be malignant cells passing through the lymphatics, or there is an inhaled particle that is larger than 20 micrometers that has fallen into the alveoli. Okay, so such a particle actually cannot just be phagocytosed and killed by your phagocytic cells, neutrophils and macrophages. However, this particle just sits there. It is removed in bits and pieces through the lymphatic drainage, and often ends up producing a granulomatous response against this particle somewhere along the lymphatic drainage. Okay, so that is what we end up finding. So if there is no clear exogenous exposure, then probably this granulomatous response is an exaggerated response to something. Okay, so that disease is then actually sarcoidosis or any other immune process with excessive granuloma formation. Now, the third possibility is that it could be a malignancy, okay, and those are malignant nodules. So the important thing is they show quote unquote social clustering. So they're almost talking to each other, and they don't spare the septa. Now, one very interesting thing is, if you had noticed at the hilum, the lymphatic, one of the lymphatics is passing right next to the pulmonary artery branch. It's all right next to each other. Now, if you have, opacities forming around this, they appear to almost be studding the pulmonary artery branch. So that pulmonary artery studding is something that is very specific. So pulmonary artery studding, you can see this is a branch of the pulmonary artery, and on top of that, say for example, this is a branch of the pulmonary artery, you see dots on this pulmonary artery. So perilymphatic nodules do not spare the visceral pleura or the septa. They also stud the pulmonary artery, and this becomes very important later on in our discussion. Okay, they stud the pulmonary artery. So essentially, in summary, you could have perilymphatic nodules due to cellular aggregates forming around central or septal lymphatics in response to an inorganic particle that is larger than 20 micrometers in diameter. So this includes essentially all occupational lung disorders, or it could be cellular aggregates forming without any exogenous exposure. So that would be in sarcoidosis. It could be a malignancy, lymphangitic carcinomatosis. Could also happen with a non-cellular accumulation, that is amyloidosis. So these are the causes of a perilymphatic nodules, and we've understood. There is another pattern called the bronchovascular pattern. So say you have perilymphatic nodules, but they are not that prominent distally. Okay, they are more along the central lymphatics than around the peripheral lymphatics. So then what happens is that it becomes very difficult to differentiate it from a central lobular nodule. So how do you differentiate it from a central lobular nodule? You differentiate it by looking at the pulmonary artery branch. Okay, so branches of the pulmonary artery. Now, as you can see here, the branches of the pulmonary artery, they appear to be studded. Okay, there are nodules along them. Now, obviously, if you have a centrilobular pattern, they're not going to stud the pulmonary artery, because it's the pulmonary artery itself or its wall that is inflamed. So it's going to be diffusely inflamed. So there'll be a thickening maybe, but there is not going to be studding. So this kind of studding that you see along the pulmonary artery branch, okay, that is highly specific for perilymphatic node process. But just to cause confusion, we call it, instead of calling it a perilymphatic pattern, we call it a bronchovascular pattern. Please remember, bronchovascular pattern is essentially just a perilymphatic pattern. Okay, and the differential diagnosis is still the same. Now, the last type of pattern that you get is what is called a random interstitial nodular pattern. So here what happens is that something is coming into the lungs through the vascular supply or through the pulmonary artery, and as you can see, these nodules are forming along branches of the pulmonary artery. Now, as is quite obvious, the pulmonary artery branches separate from each other, or they diverge from each other as they go deeper into the pulmonary bronchopulmonary lobule. So these structures or these nodules appear to almost be repelled by each other. Okay, they maintain a certain distance. Okay, and because they maintain a certain distance, I call them asocial. Okay, so they are introverted, much like me. So because of that, they try to avoid each other. So we end up getting these nodules. So we get a centrilobular pattern like nodule in the center. Okay, you could get that in the center, but you also get similar nodules nearby, but not clustering together. They are in loosely packed clusters. Then obviously they are going to not affect the venous side, because they'll get stuck in the arterial side. They, however, could secondarily be removed by lymphatics. So you could get some nodules arising along the lymphatic drainage. However, the thing is, then you would say, how do I differentiate it from a perilymphatic nodular interstitial pattern? The only thing essentially that differentiates it from a perilymphatic nodular interstitial pattern, the two things, is that a perilymphatic pattern would have pulmonary artery studding, which we've seen also helps you differentiate it from a centrilobular nodular interstitial pattern, and a perilymphatic pattern shows social clustering. So the nodules tend to coalesce, or they're almost trying to get into each other, whereas here the clustering is very loose. They don't want anything to do with each other. Okay, so this is not the actual this thing CT appearance. The actual CT appearance is essentially of these, diffusely placed nodules that are they maintain distance from each other. They may or may not involve the septal fissure. Okay, so these essentially indicate that there is something coming in from the hematogenous supply of the lungs that is within the pulmonary artery, and they may then secondarily involve the lymphatic channels. So see, as you can see, these clusters are very loose. They're not closely clustered like perilymphatic pattern. The thing that I find most useful is to look at the pulmonary artery and see that the pulmonary artery here is essentially smooth. There are no nodules along it. So that helps me say that it is actually a random nodular pattern and not a perilymphatic pattern. Okay. So these cells could in turn be hematogenously spread infection, or they could be metastasis. So that is the thing. So in summary, we've got basically three patterns. We got central lobular pattern, we got a perilymphatic pattern, and we got a random pattern. Okay, central lobular pattern is due to inhalation of organic particles through the respiratory tract, which are less than 20 micrometer in diameter. Perilymphatic pattern is due to inhalation or intake of particles that are either larger than 20 micrometer or some kind of cellular or non-cellular aggregation along the lymphatics. Okay, and random patterns are essentially due to hematogenous spread of either an infection or a malignancy into the lung. So what we find is that nodules touch the pleura in case of perilymphatic and random. In random nodules, they might touch the pleura, they need not. The important way to differentiate them is that central lobular nodules are essentially very evenly paced and it's almost like a recurring pattern, whereas your perilymphatic nodules almost want to talk to each other, so they are social. Okay, whereas random nodules don't want to talk to each other, they want nothing to do with each other, so they remain separated from each other. And we've understood why that happens. That is because they are forming along the branches of the pulmonary artery, and the branches of the pulmonary artery, as you go more distally, are actually branching out. Okay, they are moving away from each other. Okay, similarly, the other thing that is very specific is what we call pulmonary artery studding. So pulmonary artery studding essentially only happens with a perilymphatic pattern. A bronchovascular pattern is a perilymphatic pattern where the predominant nodule formation is happening along those lymphatics that are right next to the pulmonary artery branch. So as a result, they show pulmonary artery studding, but you may not have nodules along the septa. So it causes confusion with the central lobular pattern. But central lobular pattern naturally cannot show pulmonary artery studding. These are the three patterns, and there are two derived patterns. One is the bronchovascular pattern I have shown, and central lobular patterns, when they are due to a pathology that is growing within the bronchiolar lumen, can fuse with each other, producing what we call the tree in bud pattern. So essentially you have 5 nodular interstitial patterns. 3 of them are true patterns, 2 are derived patterns. Okay, now we have also pure septal thickening. So pure septal thickening could be that the septum is actually just diffusely involved by a fibrous process, or something has been deposited such as amyloid inside it, or say the lymphatics are blocked, so now fluid is accumulating inside it. So in that would cause the septum to become prominent diffusely. Okay, or it could be a nodular pattern. So along the septa there could be nodule formation. So that would be an extension of our perilymphatic pattern, because we've already discussed perilymphatic is along the lymphatics, would block lymphatic drainage, therefore could cause the septum to become more prominent. Okay, now before I end this discussion, there are 2 clinical questions that arise whenever you're looking at lung opacities. Okay, those are as follows. One is, if you see a consolidation, there is always the doubt, is it an infection? Okay, and like I've told you, there is only one specific imaging finding that suggests infection, and that is your tree in bud nodular interstitial pattern. Okay, second thing is it a malignant nodule? So there is no one specific finding that indicates malignancy, but there are a group of findings that we can point to saying that it is a malignancy. So let's get into that. So is it an infection? So pulmonary infections essentially pass through 2 types of they develop through two types of processes. They can start off as an inhaled particle that is getting stuck within the bronchiolar lumens. So that particle would be what it would be, that would produce a centrilobular pattern, centrilobular nodular interstitial pattern. That pattern would then progress to a tree in bud pattern as the pathogen grows. That tree in bud pattern would then cause inflammation around that area, so that would become less well defined and produce opacities that are essentially branching out from each other. So that is called a multi-acinar opacity or a multifocal acinar opacity. And then finally that inflammation would fuse with each other to produce a consolidated pattern. So this is the first pathway through which you can get an infection. The other pathway is you just have a ground glass opacity, and that ends up producing a consolidation directly. So now either of these two processes can end up resulting in necrosis in that area, and that can, if it is well defined and little slow, it can produce a cavity, and if it is a very rapid process, it can just produce necrosis in that entire area, producing something called necrotizing pneumonia that we'll come into later. Now, the third thing that can happen is a very slow growing infection would get walled off by a granuloma and then subsequently fibrosis, and produce a very sharply defined opacity, which we just studied is a nodule. So a nodule can also then secondarily cavitate. Okay. Now, these are the infective agents, and feel free to take a screenshot or pause the video and look at this. So what you can see is viral infections essentially can cause either ground gas opacity becoming a consolidation, or they can go through those four stages. Okay, so typically RNA viruses more commonly cause a ground glass opacity that develops into consolidation. This is because RNA viruses actually activate TLR3 and 7, and DNA viruses activate 7 and 9. And when we get into the basic immunology portion series, we'll understand that TLR7 and 9 actually produces interferon alpha and gamma, whereas 3 and 7 predominantly produce interferon alpha. And interferon alpha is a molecule that signals to surrounding cells that there is a viral infection, shut down your protein synthesis. So it essentially is like a locally spread signal that is telling surrounding cells that there's a viral infection, let's shut everything down. So the opacity that you see follows that pattern, almost radiates outwards, and that produces a ground glass pattern. Okay, these are the RNA viruses that cause respiratory infections. So we know them: the coronavirus, adenovirus, rhinovirus, influenza virus. DNA viruses, the only one that causes infections in a immunocompetent person is your respiratory syncytial virus. So as you can see, there is a certain degree of overlap between the respiratory syncytial virus and the influenza virus. They can produce the other pattern also, but they are more likely to produce the respective pattern. So influenza is more likely to cause a ground glass opacity becoming a consolidation, and RSV is more likely to go through those four stages and then produce consolidation. The thing is, what is important is, see, tree in bud is specific for infection, but if you see multiple of these opacities, so you see ground glassing and you see consolidation, that slightly increases the probability that it's an infection. Similarly, if you see tree in bud opacities and then you see a consolidation in the same CT, it indicates that the patient has an infection. So a combination of these together, okay, a nodule and a consolidation, that increases the probability of a pulmonary infection being the likely etiology. Now, in immunocompromised hosts and in immunocompromised patients, the etiology also changes. So mycobacterial infection, that is specifically tuberculosis, passes through these four stages, but again it depends on how immunocompromised the patient is. If the patient is very immunocompromised, mycobacterial infections may produce completely different patterns, particularly the random pattern or the miliary pattern, random nodular interstitial pattern. So we'll come into that in detail. Okay, however, in immunocompetent people and even in most immunocompromised people, it goes through these four stages. Okay, but what I would want to highlight very specifically is that tree in bud is not specific for mycobacterial infections, it is specific for an infection. Okay, now see, DNA viruses also cause damage in immunocompromised people. When a person is immunocompromised, the immune system responds in a very random way. So in immunocompromised people, DNA viruses typically cause GGOs followed by consolidation. The only exception to this rule is varicella infections, where actually the virus itself is inducing cell death. So that we'll see, it produces a necrotizing pneumonia. So this is a multifocal consolidation, as we've seen already. So is this an infection? The thing is, it could be technically, but it depends on the clinical context, because we don't have any specific findings suggesting infection. We don't have tree in bud, nodular interstitial pattern. We also don't have those multi-acinar opacities. So this is definitely a multifocal consolidation with some GGO, but I definitely can't say that it's an infection or it is not an infection. Okay. So now this is again, you are seeing that, say this is a multifocal opacity consolidation in some other area. Here there is no consolidation, and you see that there is a tree in bud pattern here. Okay, so does this mean it is tuberculosis? No, it means that it is an infection. Okay, so that consolidative process is likely an infection. I definitely cannot say it is tuberculosis. And see, in places like India where I practice, tuberculosis is very common. Okay, it's endemic to our country. So because of that, often a tree in bud pattern is caused by tuberculosis. Okay, but please remember, in the right clinical context, there are other differences. Any infection, but bacterial infection, DNA virus infection, a mycobacterial infection, any of these could produce a tree in bud pattern, even an endemic fungal infection. Okay, this is not specific for tuberculosis. It is specific for infection. What is specific for tuberculosis is the combination of fibrosis and consolidation. Okay, so and cavities. So that is called a fibroproliferative or a fibrocavitatory presentation. We'll come to it later. Okay, so this could be any of these. It could be a bacterial infection, it could be a mycobacterial infection, it could be a DNA virus infection, even less commonly an RNA virus infection, and it could be even aspiration pneumonia. Okay, so it just depends on the clinical context. And the only thing is that in India, the base rates of all of these diseases are so skewed, that is, tuberculosis is so common that the pretest probability almost always indicates that tuberculosis is almost 10 times more likely in any given scenario. Okay, so the other question that we need to answer is the nodule a malignant nodule? So one thing is, there are some pulmonary nodules that have very specific imaging findings. So those are not malignant nodules. So what are they? I use the mnemonic classic. Okay, classic stands for C for congenital pulmonary alveolar malformation. So it's a finding that you would find incidentally usually. L stands for lipoid pneumonia. Okay, which we'll come to is of cause of consolidation. So the lipid would produce very characteristic decreased attenuation compared to a normal consolidation. A stands for AV malformations. S stands for sequestration, which is again a congenital malformation, where the part of the lung is actually getting its blood supply not from the pulmonary artery, but it's getting its blood supply from the bronchial artery, and is not in continuation with the general respiratory pathway. You have S for spherical consolidation or a spherical atelectasis. Then we have I for invasive aspergillosis or a non-invasive aspergillosis, both of which have very specific imaging findings, and C for calcified granule. So if you, as would be more normally the case, have no specific features, then the pulmonary nodular mass has to be assessed for risk of malignancy based on a combination of clinical and imaging features. Now, clinical features are obviously all of the clinical risk factors you have with a pulmonary malignancy. So exposure to essentially smoking, okay, family history, prior irradiation of the lung. Okay, instead, right now we'll concentrate on the imaging findings. So there are 10 parameters that we use, and I use this mnemonic A1, B2, C3 and D4. Okay, so A stands for air bronchogram. So air bronchogram does not happen in a pulmonary nodule most of the time, so it strongly decreases the possibility that it is a malignancy. A well-defined border indicates it's not a malignancy. A border that is poorly defined and the lesion appears to be infiltrating surrounding areas indicates a malignancy. Shape, a stellate pattern or something like that indicates it could be a malignancy. Cavitation could happen in a malignancy, it could happen in other processes also, but a cavitation that is eccentric indicates it's a malignancy. The presence of calcification actually argues against the presence of a malignancy. There are specific patterns of calcification that argue against it. Okay, like popcorn calcification. Now, clustering now could go either way. So like I've discussed earlier, there are some perilymphatic patterns that produce a very interesting social clustering. Okay, whereas if you have a large mass in the center and there are smaller masses around it, okay, that could be a perilymphatic pattern, with a consolidation in between. So therefore, like we've discussed, perilymphatic patterns can also be due to malignancy, so that would increase your risk of malignancy. The diameter or size of the lesion, so this is actually one of the most important things. So more than 3 millimeters, the risk of a lung nodule being a malignancy is very, very high. Okay, it's almost 94%, and less than 1 millimeters, around 6%. So it's 94 plus 6. Okay, then we have your density. So irregular density or areas of what we sometimes call necrosis, okay, non-homogeneity within the lesion indicates it could be a malignancy. D again stands for doubling time and distribution. So malignancies have very specific distribution within the lung, and doubling time is the amount of time it takes for the nodule to become double of its original size. So only a malignancy would have a short doubling time. So if you have none of these features, we call it a low risk. So in that situation, we can just wait and watch. If you have any of these features, it is usually prudent clinically to take a biopsy, a histopathology, and look for a malignancy. This is what I need you to understand. So I need you to understand what are the types of pathologies that cause increase in pulmonary attenuation or cause a hyperintensity within the lung parenchyma. Okay, so those, like we've discussed, could be obscuring the alveoli, producing a consolidation, or obscuring the alveoli and producing loss of volume, that is an atelectasis, obscuring the alveoli and increasing the volume or having a positive effect or compression of the surrounding structures, that would be a nodule and would be very sharply demarcated. It could also be an enhanced appreciation of the septum, so that would be a pure septal interstitial pattern. You could have those interstitial patterns fusing with each other like lines, so that would be a reticular interstitial pattern. And then we could have nodules due to passage of material along lymphatics, along the vasculature, that is the pulmonary artery, and that would produce three specific patterns. It would produce a central lobular pattern if it is due to an inhaled pathogen or particulate matters less than 20 micrometers. It would be a perilymphatic pattern if it is a process that is passing through the lymphatics, like a granulomatous process, either induced by an inhaled particulate matter more than 20 micrometers in diameter, or induced by an autoimmune disease like sarcoidosis or other granulomatous autoimmune disorders. It could also be a random pattern which is due to hematogenous spread of infection or malignancy into the lung, okay, along the branches of the pulmonary artery. And we've learned how to differentiate between those different entities. Finally, we've seen that imaging allows you, under certain very specific circumstances, to say whether or not that imaging finding is related to an infection. It also gives you an idea regarding the risk of the pathology, particularly a nodule or a mass, being a malignancy. So this is what we can say based on an HRCT, and therefore these are the limits of the diagnostic utility of an HRCT. Beyond this, what is gleaned depends on the clinical context. Okay, so I hope this is clear, and I'll see you in the next video.